Introduce Dr. JeffryLife. Most of you probably know Jeff. He is the founder and CEO of Senegenics.
I guess you should take this one.
Dr. Life in Las Vegas. Just to keep himself out of trouble, he's also completing his MBA at Auburn University and finishing his upcoming book. And I would venture to say that Jeff has the most viewed naked torso of a man over 70 in a living being out there. I was going to say of any naked torso of a 70-year-old, but then I remember that sculpture of David that's over there, which is probably a little more viewed and a little older. And I'd like to introduce Jeff to do his talk on current status of diagnosing and treating adult growth hormone deficiency.
Thank you. Why doesn't everyone stand up for a minute, move around? How about now? How about now? What'd you do? Magic. All right, that's it. That's the end of your break. Well, first of all, I welcome all of you to our AMMG conference. This is what number? Got a bunch. This is the biggest turnout ever, so this is spectacular. Age management medicine has become more and more popular. We get more and more physicians interested in pursuing this kind of medicine. So I'm ready to start. There we go. So over the last 2 or 3 years, I've been responsible for developing the criteria we use to diagnose, Senegenics uses to diagnose and treat growth hormone deficiency. And so what I'm presenting today is the position Senegenics has taken on diagnosing and treating growth hormone deficiency. How's that? Where do I aim this?
Right and left.
Oh, okay.
Is the pointer working?
It's not. Sorry, everybody.
Forward.
Okay. Okay, so because growth hormone has become, because it's been abused so much over the last few years, it has pretty much come center stage in controversy. And because of that, physicians need to be very careful about who they prescribe growth hormone for. Federal law treats growth hormone differently than other scheduled drugs, controlled drugs. Growth hormone falls under the FDA scrutiny. FDA is the one that controls and oversees the use of growth hormone, not the DEA. Since 2009, last year, about April or May, the pharmaceutical companies changed the language in their package insert. They used to say that they would recommend a provocative stimulation test to diagnose growth hormone deficiency. Now they say that it's required, must be confirmed. This has really changed things in the eyes of Senegenics as to how we go about diagnosing growth hormone deficiency. And they specifically say that it cannot be used for anti-aging purposes or for purposes of building muscle or for athletic enhancement of athletic performance. So Senegenics, because we're a large corporation, decided to err on the side of caution. And so we have decided that we want to when we initially see our patients and we think they're growth hormone deficient based on blood levels and based on all the other things that go along with growth hormone deficiency, which I'll be talking about, if we think they're growth hormone deficient, we wait for 2 months. We correct all their other hormonal deficiencies. We fix their nutritionals, get them on the right nutrition, get them on the right exercise, and then we repeat blood work again in 2 months. Most people will increase their own production of growth hormone. It's pretty dramatic, really. But there are some that will not, and those are the people that we think we need to test, do a provocative stimulation test before we treat them with growth hormone. So we only initiate growth hormone therapy if they fail a stimulation test. This is a very conservative, very safe approach. I've created the growth hormone guidelines, and it summarizes the science, and this is really pretty much what I'm talking about today. And I discuss the role of growth hormone in medical practice, and it's really not intended to establish a standard of care for growth hormone treatment. I think each physician has to make up their own mind about each patient and decide whether they really will benefit from growth hormone or not. And they need to decide if they want to go ahead and do the provocative testing, which I will discuss later. So the Endocrinology Society has described growth hormone deficiency as decreased energy levels, social isolation, lack of positive well-being, depressed mood, increased anxiety, increased body fat, especially central adiposity or visceral fat, decreased muscle mass, decreasing bone density, increased LDL cholesterol, and ApoB, decreased HDL cholesterol, decreased cardiac muscle mass, impaired cardiac function that was just discussed, decreased total and extracellular fluid volume, decreased insulin sensitivity, and increased prevalence for impaired glucose tolerance, increased concentration of plasma fibrinogen and plasminogen, accelerated atherogenesis. These are all very bad things, as you know. And all these metabolic changes that I just described increase the risk of atheromatous cardiovascular disease. And we see this in patients that are hypopituitary, and we see it in patients that are low in IGF-1. Up until 1986, growth hormone was harvested from cadavers. So at that time, a lot of thought had to go into who to put on growth hormone. So they devised this growth hormone stimulation test, which is a provocative test that stimulates the pituitary to produce growth hormone. And at the time, insulin stimulation was the test that was used the most by endocrinologists. But since 1986, growth hormone has become commercially available, and with the recombinant gene technology that we use for insulin. And so all these issues surrounding the transmission of disease from cadavers is gone as of the creation of this new growth hormone, recombinant gene growth hormone. So the stimulation test, as I said, was used mostly by endocrinologists, but there are a lot of dangers with the insulin tolerance test. Insulin tolerance, as you can well imagine, you give someone insulin and their blood sugars plummet. The whole idea is to drop blood sugars, which stimulates the pituitary to produce more growth hormone. But you can have seizures, you can have unconsciousness. It's contraindicated in anyone with coronary artery disease, and that could be obvious coronary artery disease or occult coronary artery disease, or anyone with seizures. Murray and his group described all growth hormone stimulation tests as plagued by poor reproducibility. and labor intensive. And they feel that there's very little data to support the use of all provocative stimulation tests. And over the last 3 or 4 years, there's been more and more growing criticism about the use of the insulin tolerance test. And I have references here. There are a ton of references in what I gave you. These references cover just about everything that's happened over the last 15 years with growth hormone. There are several recent studies that have demonstrated the clinical usefulness of growth hormone supplementation without the insulin tolerance test, or without requiring that someone fail it. And now there are several researchers that feel IGF-1 is a more reliable diagnostic and therapeutic marker of growth hormone deficiency. There are 5 references right there. These are all new within the last few years. The society, the Growth Hormone Research Society, concluded that in association with appropriate clinical signs and symptoms, and in conjunction with proper laboratory evaluation, you can diagnose growth hormone deficiency in the absence of the insulin tolerance test. In spite of that, the FDA has maintained their position that the ITT, or that a provocative test, must be done before you can diagnose someone as having adult growth hormone deficiency. One of the biggest proponents of this is an academician named Tom Perls from Boston. Tom is a zealot when it comes to going after people that prescribe growth hormone for what he considers to be anti-aging. And he has had an impact on Congress and on the AMA to get them to think in terms of requiring provocative testing to diagnose growth hormone deficiency before you prescribe growth hormone. The Growth Hormone Research Society also points out that people can have normal IGF-1s, including Williams' textbook of endocrinology, and still be deficient in growth hormone. Let's talk about growth hormone and health. As in all disease states, as you know, there are varying degrees of severity. And there is mounting evidence that adults with growth hormone deficiency or insufficiency have impaired health, and would benefit tremendously from growth hormone replacement therapy. This study maintains that IGF-1 levels at the mean or 1 standard deviation, actually between 1 and 2 standard deviations, are necessary to maintain optimal health. If you maintain IGF-1 levels in this range, you improve overall health. McGearkey and her associates looked at it differently. They looked at what were the IGF-1 levels that were associated with good health. And she found that if people were within 1 to 2 standard deviations above the mean, that's when optimal health was achieved. If they were at the mean, they began to have not so optimal health. And as they dropped below the mean, their health worsened. Rubinoff and Capola, 2 different investigators, 2 different studies, pointed out that there's an inverse relationship between IGF-1 levels and mortality. And they felt that these studies used IGF-1 as an actuarial risk. And they established a direct relationship between its measurement and patient outcome. In the same way that we use all the other things we look at, LDL, all the other markers of disease. Rubinoff's study was over a 22-year period. It was part of the Framingham study, and he found a 13% lower mortality rate for IGF-1 values in the upper 2 quartiles when you compared them to the lower 2 quartiles. And this was independent of all the other risk factors plugged into this thing. The Rancho Bernardo study, it was similar to the Framingham study. And this was over a 13-year follow-up. IGF-1 levels were inversely associated with both total mortality and cardiovascular disease. For every 40 nanogram decrease of IGF-1, there was a 38% increase in total mortality. I mean, this to me is just amazing. Let's talk about growth hormone as people age. And this was already discussed earlier. Elderly people are at 4 to 5 times the risk for cancer, TB, herpes zoster, 6 to 7 times the risk of fatality from pneumonia when you compare them to younger adults. This is thought to be due to IGF-1 levels and growth hormone levels dropping. By age 60, most adults have a 24-hour growth hormone secretion rate indistinguishable from those of hypopituitary patients with lesions in the pituitary. The fall in growth hormone secretion seen in aging is accompanied by changes in body composition, lipid metabolism, immune function, and a progressive loss of muscle mass, which, as you know, is called sarcopenia. Sarcopenia is one of the major causes of disability and of people ending up in nursing homes. And the increase in body fat that people get when they have low IGF-1 levels is almost exclusively visceral fat, which is, as you know, very metabolic. It's very different than subcutaneous fat. It takes on a life of its own and creates adipokines, which put people at risk for cardiovascular disease, Alzheimer's, type 2 diabetes, and insulin resistance. The similarity between the negative effects of the adult growth hormone deficiency syndrome and aging have led many investigators recently to speculate that growth hormone deficient state of normal later life may have a causal relationship to the undesirable physiologic changes we see with aging. And Saving, he and his group believe that growth hormone therapy may be an effective approach to promote and maintain health in old age, and points out the need for long-term studies. There are no long-term studies. We've already heard a great lecture on cardiovascular disease. I'm going to add a little bit to that. Conti has an article that's about 2 or 3 years old, and he looked at his group looked at IGF-1 levels, and they felt that IGF-1 levels alone can predict whether people will develop cardiovascular disease. And he considers it that it should be one of the things we look at in the same category as LDL and HDL. And we need to look at IGF-1 levels because they independently can cause low levels can cause people to develop disease. And this applies even after they adjust for all these different things: body mass index, smoking, hypercholesterolemia, menopause, alcohol intake, on and on and on. They plug all this in, and still IGF-1 comes out as a great indicator of disease risk. Denti studied growth hormone levels and as it relates to stroke, and he found a tremendous, potent inverse relationship between IGF-1 levels and the outcome of people that have strokes. For each 20 nanogram per milliliter increase in IGF-1 seen in stroke patients, the mortality risk was reduced by 30%. 20 nanograms is not very much. So the lower your IGF, if you have a stroke and the lower your IGF-1 level is, the worse your outcome is going to be. Let's talk about growth hormone therapy and cancer risk. This is Tom Pearl's biggest thing. He throws this out every time he's on TV. He says people that are taking growth hormone are increasing their risk for cancer. He has not one shred of evidence to back it up. Not one article, nothing, zero. The literature does not support this notion. The AACE and the Endocrine Society state there is no evidence that the incidence of intra or extracranial tumors is increased by growth hormone therapy. There's no evidence that growth hormone replacement. Wait, my screen just went. There's no Dr. Shlomo Melmo. You may remember him. He was on 60 Minutes with Alan Mitz. He was the guy that Alan was on. Then they interviewed Shlomo, and then back to Alan. And Shlomo didn't feel that people should be taking growth hormone. But he didn't. I can't recall whether he said it might increase cancer risk, but he has actually written a paper, an editorial that shows no increased cancer occurrence has been observed in surveillance studies of growth hormone replacement therapy in pituitary deficient patients. In 2001, 9 years ago, the Growth Hormone Research Society studied this extensively, and they felt that if you are treating someone with growth hormone, there is no need to do anything in addition to the usual monitoring for tumors. Let's talk about growth hormone therapy and obesity. As you know, we have an epidemic of obesity in this country, and it seems to only be getting worse. And it's mostly the obesity that's causing, most of the obesity we see is abdominal or visceral, which is a lot different than gluteofemoral. Visceral obesity, as I said earlier, causes huge metabolic problems, metabolic syndrome, and puts people at risk for cancer, stroke, insulin resistance, diabetes, and Alzheimer's. And visceral adiposity is also recognized to be associated with a decrease in IGF-1. So which comes first? The fall in IGF-1, then visceral adiposity, or is it the other way around? No one really knows for sure. If you treat people with visceral adiposity with growth hormone, even if they're not, quote, growth hormone deficient, they will start to lose visceral fat. If they are diagnosed as growth hormone deficient, they'll even lose more visceral fat. And as visceral fat is lost, you improve cardiovascular disease, and you decrease all the risk markers associated with insulin resistance and disease. Growth hormone treatment increases lean body mass while it's getting rid of visceral fat. How about growth hormone therapy and exercise capacity? Growth hormone therapy, a 2008 article showed that if you replace growth hormone in deficient adults, and I don't think that they've determined their deficiency by stimulation testing, it improves VO2 max. And here's how about growth hormone and diabetes? When it's given to abdominally obese men, it leads to a reduction in abdominal fat and a corresponding improvement in insulin sensitivity. Correction of growth hormone and IGF-1 deficiencies with lifestyle. Nutrition plays a big part in how much growth hormone you produce. If your IGF-1 falls rapidly if you fast. If you have a high-fat, low-carbohydrate diet, your IGF-1 will fall. On the other hand, if you have a healthy amount of fat and low glycemic, your IGF-1 levels will increase. And you need to take the right micronutrients. And this is why I think our patients, over an 8-week period, improve their own production of growth hormone. And they can add 100 points to their IGF-1 level. The question is that enough? I don't know the answer, but I have my own suspicions that it's not enough. There's more about abdominal obesity. And this Article 70 thinks that that the decrease in growth hormone secretion is the result of rather than the cause of the obesity. Exercise can play a huge role in your own production of growth hormone. And you need 10 to 20 minutes of aerobic exercise, and the intensity of the exercise is also important. You need to do kind of over the top on some of your exercise to really get your pituitary to produce more growth hormone. Sleep. This is when we make our growth hormone with deep sleep. And invariably, if you have a patient that doesn't sleep well, that has sleep apnea, they will have low IGF-1 levels. It's really important that we all address sleep issues in our patients. If you can get people to sleep better, they will produce more growth hormone. These are the signs and symptoms of adult growth hormone deficiency and all the related diseases that are associated with low IGF-1. When I say low, I mean probably below 150, 175 on down. That's low. Quality of life. We have a questionnaire that we ask patients 25 questions about their quality of life. I consider 5 yes answers or more to be significant. Beck Depression Inventory, you all know about that test. If someone falls into the 10 or above in mild to moderate depression, that's significant. And that's associated with people that have deficiencies in growth hormone. Fatigue, metabolic syndrome, truncal and visceral obesity, decreased bone mineral density. We do DEXA scans, and I can tell you that patients that are low in IGF-1, we correct that. A year later, their bone density improves, men and women. Osteoporosis is a disease of men as well as women, and it's pretty much ignored in this country. 1/4 of all men will develop osteoporosis. Decrease in muscular strength, sarcopenia, hypogonadism. So if you have low IGF-1 levels, you probably have low testosterone levels. Decreased energy and vitality. This is probably the biggest reason people come to my clinic. They notice that they just don't have the energy and vitality that they used to have. Hypothyroidism, hyperinsulinemia, dyslipidemia, depression, abnormal fasting glucose. Obstructive sleep apnea is related to people that have low growth hormone levels, low IGF-1 levels. Insulin resistance, obesity, and being overweight. Declining sexual function, that's another big reason men come to my clinic. Family history of coronary artery disease. So if a patient has a family history of coronary artery disease or Alzheimer's disease or cancer, that's kind of a flag that you need to really think about. Are their growth hormone levels adequate? Sleep disturbances, increased CRP, and other inflammatory markers. Atherosclerotic vascular disease, declining cognitive function. We do a cognitive test, and people that have low IGF-1 levels score poorly on that. And if we correct their IGF-1 levels, next time they do it 6 months or a year later, they improve. Cardiac decompensation, hypertension, reduced exercise capacity, decreased libido, endothelial dysfunction, a history of head injury. Anyone that has had a head injury, you need to really think about what their IGF-1 level is. People that have head injuries, more often than not, have low growth hormone production. Adverse cardiovascular risk profile and elevated estradiol in men. So So if you have a less than one standard deviation above the mean, that to me is, if your IGF-1 is less than one standard deviation above the mean, so we're talking about 175 on down, then you are at increased risk for age-related disease. IGF-1 levels are also considered to be an independent risk factor for cardiovascular disease. They can be low or normal in deficiency states. So these are our Cenegenics contraindications. We have taken the position, the very safe position, that we will not prescribe growth hormone until a provocative test is done. Do I think this is right? I mean, it's right for Cenegenics, but do I think it's philosophically right? We don't do this with any other hormones. We don't do some kind of provocative test for testicular dysfunction. We don't do any kind of provocative testing for thyroid dysfunction. It's only because growth hormone has become so controversial, and we have zealots like Tom Pearl and other people that feel that it's their mission to stop the use of this. Pregnancy is a contraindication to prescribing growth hormone. Malignancy, although that's controversial too, because if someone has a malignancy and has a very low IGF-1, their immune function is compromised, their whole body is compromised. They may well do much better with growth hormone. But diabetic proliferative retinopathy, sclerosing diseases of the liver and lungs, benign intracranial hypertension, and uncontrolled diabetes. So I've listed there that what we consider the clinical assessment. If you're going to prescribe growth hormone to someone and you're not going to do the provocative test and you're going to base it on their IGF-1 levels and how they are clinically, you really need to do all this comprehensive stuff, I think, to really support your treatment. So gone are the days of cadaver growth hormone. The supply we have today is very safe, available and easy to use. It's expensive though. It costs probably $1,000 upwards to take maybe a unit of growth hormone a day. That's the usual starting dose I use, is about a unit a day. Most people do well on 1 unit a day. These are the recommendations that we used when we first assess a patient for growth that we think is growth hormone deficient. We review all the outside medical records, labs and diagnostic testing, sleep studies. We got to make sure that their underlying sleep disorder is corrected. So at 8 weeks, if they come back for the provocative test, we need to make sure that they're sleeping better, that they've had a sleep study, and that that's taken care of. We make sure that we implement the nutrition and exercise program and correct all the other hormonal deficiencies. We repeat the quality of life test at 8 weeks, and if they have not improved, and if their IGF-1 levels have not improved, then we consider having them come back for a provocative stimulation test, which I'll talk about in a minute. Well, I repeat the CNS vital signs. That's our cognitive study that we use. I repeat abdominal girth, or the DEXA. If they are, you just have them measure their waist. If they're not in town and can't come back for a DEXA. That we have an energy strength fitness questionnaire we ask. Have them repeat that, see if that's improved. And if after all this you really believe that they are deficient, then we suggest they come back for a glucagon stimulation test. Glucagon is not as dangerous as insulin. and I'll go through how we do the glucagon stimulation test. We get blood work every 3 to 4 months, check hormone levels and all the other markers of disease, and we want to see our patients at least once a year. These are my own personal suggestions. This is not the Synergenics policy. This is my own. I think you need to do a good physical exam, annual blood work, the quality of life score, back depression inventory score, percent body fat. The best way to do that is with a DEXA by far. DEXA will give you the grams of body fat, the grams of lean muscle, the percent of body fat. It's the gold standard for assessing body composition. Bone mass, it's the gold standard, as you know, for bone mass. The lipid profile, VAP test if indicated. Hemoglobin A1Cs, fasting insulin, and cardio-CRPs. I've started doing 2-hour glucose tolerance tests on some of my patients. That's the best way to diagnose insulin resistance and diabetes. I do carotid ultrasound studies to assess intima media thickness, plaque character, and stenosis, and this gives me an idea about their entire vasculature. I do VO2 maxes to assess changes in their cardiovascular fitness, CNS vital signs for cognitive testing, energy status, and I document all of this in the medical record. Okay, let's talk about the glucagon stimulation test. It's recently been promoted as being much safer than the insulin test. You cannot give it to someone that's malnourished or that has fasted for more than 48 hours. Patients during the test may feel nauseated and may become hypoglycemic, so you got to be ready to take care of that. The patient is to fast overnight and then is recumbent throughout the entire 4-hour test. Start an IV with saline and draw bloods through that IV. 30 minutes prior to the test, you set up the IV. Then at 0 time, you take a blood sample for glucose and growth hormone. Then you administer 1 milligram of glucagon IM. Then at 90 minutes, you take your first sample of growth hormone, blood sample for growth hormone. Then every 30 minutes after that until 240 minutes. The peak response to IM glucagon usually occurs at 3 to 4 hours after the administration of glucagon. If it is greater than 3 micrograms per liter, then they have passed the test. If it's less than 3, then they fail the test and you can prescribe growth hormone and not have Tom Pearls and the FDA coming after you. I have in your syllabus, not syllabus, but in a DVD, you have all these references. $76 references. There's not one reference in there that says bad things happen when you put people on growth hormone. Initially, when growth hormone was used, they used pretty big doses back when Rudman did this. And so there were a lot of people that had joint pain and some glucose intolerance. But I can tell you I never have had, in the 7 years I've been doing this, have ever had anyone that has had joint pain or fluid retention of significance or glucose intolerance. If they do, you just back it down a little bit and then go back up. But if you start with 0.35 milligrams of growth hormone a day, which is about a unit a day, you will not see problems. You will see big benefits. I thought maybe to finish this up, I would give you my own personal story about what this has done for me. In my 20s, 30s, 40s, and 50s, I followed the traditional American diet. I did a little bit of exercise. I went to school, I raised kids, and I had a lot of stress in my life. And when I was in my 50s, that's what I looked like. Full-blown metabolic syndrome. So in early 2000, I was diagnosed with metabolic syndrome, pre-diabetes, insulin resistance, hypertension, coronary artery disease. I had a 64-slice CT, and it showed advanced coronary artery disease. No ischemia, no chest pain, muscle mass and strength losses, declining sexual function, fatigue, and exercise intolerance. In May of 2003, I got lab work on myself and found out I was deficient in growth hormone and testosterone. My IGF-1 level was in the hundreds, low hundreds. My testosterone level was in the hundreds, mid to upper hundreds. If it's below 300, you can treat people with testosterone. So in June of 2003, I started on growth hormone and testosterone replacement therapy. I initiated a consistent, intense exercise program, cardio and resistance training. I also began, or I actually really got focused on a low glycemic, low fat diet. Not a vegan diet, I eat meat. And I've been pretty much doing that for the last 7 years, 7.5 years. This is how I look now. Age 71 3/4, that's a couple months ago, for my book, the cover of my book. There's no way I'd look like I do now. There's no way I'd feel like I do now. There is no way I'd be as productive as I am now if I hadn't started this program 7.5 years ago. Would I have passed the insulin or glucagon stimulation test, or would I have failed it back 7.5 years ago? I don't know. I might have passed it, or I may have passed it. Do I think people should be treated with growth hormone as they age? Absolutely. It makes the difference. Thank you. Now we got lots of time for questions.
Does it matter when you give the growth hormone, evening, morning?
I've always given it in the morning. Our feeling is that at night you make your own growth hormone, so why would you want to interfere with that? Just give it in the morning. That's what I've always done.
What about someone's a poor sleeper?
Well, you need to improve your sleep. You need to figure out what's going on with that. You need a sleep study. I can't tell you how many people, lean, big, thin, have obstructive sleep apnea. Men, I don't know, women don't seem to have it as much, but men, it's like a major epidemic in this country. I think everyone should have a sleep study.
It doesn't matter if you eat or don't eat, and you care about that.
About taking growth hormone?
After food
No.
or after exercise.
Well, yeah, I'd say wait an hour to 2 hours after heavy duty exercise, because you're making a growth hormone when you're doing exercise. Yes.
I am 68. I've been taking the cream for about 3 or 4 months, and I did it once before for about that period of time, and nothing really happened. Is there any other way to increase the possibilities of getting it up?
Yeah, well, don't use the cream.
Do the injections.
Use the injections. I mean, to me, it's just a no-brainer. It works so well. Why would anyone want to do something different?
Well, my doctor's right here, Dr. Clare. What do you say?
And you can use Cypionate, and I have a lot of patients that split the dose, so they give themselves 2 IM injections a week. The typical dose is about 100 milligrams a week. Yes?
Yes, the life take you to the top of
of growth hormone? Growth hormone cost, about anywhere from $600 to $800 a month if you take 1 unit a day.
So it's about roughly $1,000 a month?
It's about, if you figure 1,000 a month, that's about right. I'd say $800 to $1,000 a month.
Some insurance companies pay for it?
No.
Then you're a friend of the finally.
No, insurance companies will do everything possible not to pay for it. Even if you have someone that's failed a provocative test, they still fight. Or they'll want you to do another provocative test. So we just don't deal with that at all. Yes?
I want to know how Tom Pearls gets away with it.
I don't know.
And why haven't all the proponents and this Society of Growth Hormone Research or whatever, I mean, and the 400 age management physicians across the country, or maybe even the 1,200, and other people just don't get on the bandwagon and point that out?
Why don't endocrinologists step up and start doing things that they should be doing? I don't know the answer. We've heard all these talks about growth hormone and how helpful it is. It's amazing to me that we have to do a provocative test, which people are not going to want to do. I mean, who wants to lie there for 4 hours, fly back, lie there for 4 hours? And
Well, I'm not even talking about that. I'm talking about the fact that according to what you're telling us is there's not one shred of medical evidence in the literature supporting that there's an increased risk of carcinoma
no,
from growth
Dr.
hormone.
Rouzier covered that,
And yet he continues to propose it, and everybody believes it.
I don't know. Well, Tom is approaching his early 50s. He may change his mind.
Thank you. It seemed to me that in the beginning you talked that the FDA required the test in order to get HCG. So if you
They-
don't do the test, how do you get, and actually where do you get it? Who sells it?
Well, you can prescribe it. I mean, any doctor can prescribe growth hormone to any patient. The question is, are you breaking the law? And if you look at if you take a very tight look at this, you really need to do a provocative test. Now, Dr. Rouzier talked yesterday about insufficiency, and this is the people I'm talking about. People that have insufficient levels. People that are at the mean of IGF-1 or 1 standard deviation below. These people are headed on a slippery slope. They're going to get sick, and they're going to die of age-related diseases, and it's not necessary.
May I ask who you order it from?
We have MedQuest, or any pharmacy. You just write the script, and any pharmacy will provide it. We use Norditropin mostly. It comes in a pin that you just dial it in. It's got a little preservative in there, so you don't have to keep it refrigerated.
And just one other question, and although it sounds like you can't get it, how do you feel about the use of IGF?
I don't know much about it. I know what I've done for almost 7.5 years. I know what it's done for me, and I'm not about to change. Yes.
I've done prolotherapy and a lot of other joint injections, growth factors, platelet-rich plasma for a number of years now. From about 2001 to about 2006, I used intra-articular growth hormone and had a great deal of success with it. I was wondering if there were any different rules and regulations that would allow me to now resume what I know worked for a lot of my patients, to do 3 intra-articular joint injections over a lifetime as opposed to daily injections. Does it still fall into the same rules and regulations that you're describing? Or, I mean, does anybody even know?
That's not a legitimate use.
I'd heard somebody mention at this meeting offhandedly that if there was a traumatic injury that there maybe were different justifications for use of the growth hormone, but that's not true?
I think if you document and you really document really well, and you got some literature to back you up, I don't see how any governing agency could, like a state medical board or the federal government could do much. I think that the key is really careful documentation.
Great, thank you. Thanks for your help.
That supports what you're doing.
Yes, thank you. There are a lot of people who cannot afford growth hormone. I have a lot of patients who, of course, go through usual testing and can help balance their hormone levels in various ways. But their growth hormone may still be low or insufficient. Is there any evidence to show that the precursors are of any value, the amino acid precursors to growth hormone?
There's some data that supports that. Well, I mean, I gave you some of the nutrition stuff that helps people increase their IGF-1 levels. I think the ideal IGF-1 levels in the upper 200s or low 300s. And you got to do a lot to get it up there. If you are starting at, say, at 150, I don't think you're going to get it up there. You can get it up into the 200s by doing all these things, but I don't think you'll ever get it up to where it's between 1 and 2 standard deviations above the mean.
Do you believe there's a body fat level below which growth hormone would be contraindicated, even though multiple other parameters would be suggestive of its use?
You mean on an initial evaluation?
Yes. Well, I mean, after the usual, doing all the usual basics that you're suggesting, if people are failing in terms of multiple other areas of their health and they have a relatively low body fat, would you say that contraindicates its usage,
No.
or does not?
No. That picture, when I was in my mid-50s, I probably had 35% body fat. I have less than 10 now.
Well, but say somebody starts out and they've been through other, appropriate evaluation, their body fat's, say, 20% or 18%. Would you say that in and of itself would be a contraindication or
No.
not?
No, it depends on all the other things that are going on. If they have vascular disease, if they have poor energy levels, if they have dyslipidemia, all the things. When I decide to put someone on growth hormone, I say growth hormone deficient based on, and I go through that list that I gave you all, and I hit every one of those things that supports the diagnosis of growth hormone deficiency.
Have you had any patients with working off, for instance, a young man with low testosterone who wanted to have like a microadenoma pituitary? Would that be a contraindication to use growth hormone?
Wow. Yeah, I'd be a little afraid of that.
And my second question is, when you do replace your growth hormone, you check it over every 3-6 months. Is there a certain way you stop growth hormone and go back on it and you check it?
No. Nope. Once they're on it, I mean, I have patients that have stopped it since 2008 because of the economy. I've had a few patients that had to stop taking growth hormone. And I can tell you that growth hormone, when people start taking growth hormone, you don't feel a whole lot different. It takes weeks and months before you start appreciating what it does for you. With testosterone, if you have a low testosterone level and you start testosterone, you start feeling that within the first week. But growth hormone is very slow. And then pretty soon you start to realize, geez, I'm feeling better. I recover from my exercise better, have more energy. And it just kind of, you start, and then your skin starts looking better. And you start thinking better. I think better now than I did than I ever have. That's why I decided to go for an MBA or something. Why not?
Unfortunately, as physicians, you always live and die by the values on testing. And what happens is, I guess what you're saying, that you really don't really follow, you use the values to a certain degree, but you go more clinical response to that, right?
I didn't follow all that.
As physicians, you follow numbers, IGF level.
Okay, yeah. Okay. Well, I treat in part with numbers, but I treat clinically. I go with how the patient's doing. And I make sure I don't get levels too high. And if someone comes in and I've treated them with testosterone, and their free testosterone is 130, which is at the bottom where I think it should be, and they're feeling great, I don't change it.
Okay, so I have one comment and two questions. First of all, I've been using human growth hormones for 12 years, and you can buy it fairly inexpensively at the pharmacy, $210 to $300 a vial, 15 units, Tevtropin. You're familiar with it. And the way
What brand?
Tevtropin from
Okay, yeah.
Israel, the Teva pharmaceutical, so you all can get
Is
it.
that FDA approved?
Absolutely.
Okay.
And it's a 15 IU bottle, international units, and we give it 1 unit Monday through Friday, 3 weeks on, 1 week off, so it costs the patient about $200, $250 a month for 3 weeks out of 4, number one, just for knowledge. Number two, what about the arginine stimulation test? You didn't mention that. Number three, wait, and then I'll sit down. So you're still taking human growth hormone, obviously, and how do you do that since you would fail all the regulations you just showed us, including a stimulation test?
Well, I don't know if I would or not. There are a lot of people that are on growth hormone that we prescribed growth hormone before the package insert changed. To stop those people, to take a growth hormone away for a period of time and then stimulate and stim test them, I think is malpractice. So, would I fail? Yeah, I think I would fail the growth hormone stimulation test. If I stopped growth hormone and a month from now did the stim test, I think I would. I sure as hell would feel bad, regardless. Yeah, you must always prescribe FDA-approved growth hormone. You do not want to be prescribing growth hormone that's not FDA-approved. Oh, yeah. I don't know much about that, but we based what we're doing with the glucagon on a recent article that our endocrinology colleagues said would work well. So I don't know the answer to the L-arginine. Yes?
Hi, Dr. Life. I'm Rich Lipman from Honolulu, and I myself and John Hendrickson, we carefully researched the Medicare Advantage Class D of the drug coverage for the Class D, and of the dozen insurance companies, in fact, 2 of them will cover you for growth hormone, but only if you risk your life with the insulin stimulation test. But 2 will cover you, and what that means is they'll cover 75% of the cost. But of course, there's the donut hole, which means that John Hendrickson and I, we consume $8,000 a year in growth hormone, and out of pocket that would be $3,000 a year. And so it's really interesting. If you search this for some of your patients who are more on the indigent side, that you can save some money this way.
So did you go through this insulin stimulation test?
No, I haven't done that yet. I haven't gotten around to do this, but because I don't, is it worth risking my life? Maybe not. Maybe I'd just rather pay the $8,000 out of my pocket since I have the money. But if you don't have the money, this is an alternative.
Yes.
I make money for excuse me. This is a comment on the gentleman who asked about prolotherapy and growth hormone. There's a Dr. Mark Dubik, who's an interventional pain radiologist in Charleston, South Carolina, who's been doing prolotherapy for many years, who is part of a local IRB through the hospital in Charleston. The head of the IRB is a hematologist, and they're using growth hormone for ulcers and cancer patients. Mark is doing his for prolotherapy. In the documented literature for burn wards and other wound issues, local growth hormone is precedented in the literature. So it's interesting in medicine how physicians are no longer leaders for the patient. All this evidence, all the hormones that we treat and we measure, they're high and the symptoms are low, and we give the patient more hormone and they get better. So, I think
it's a no-brainer.
It's the physician's responsibility in a sick family to stand up and call those people to task especially when you show that they don't have any evidence of what they're saying. So I think...
Well, I've done my best. I was on a TV show with...
Well, the public is probably going to drive it. So, but anyway, there is a movement towards looking at growth hormone, testosterone, locally for connective tissue degeneration and regrowth.
Now, that's all off-label use, but, you know, can you use growth hormone for off-label uses? And that's, we feel that that's treading on thin ice as a company. Yes?
JeffryLife, just to comment on that last problem that a few people have talked about, this off-label use. Maybe the doctor there can help me too, because she's an anesthesiologist. And I've been doing that for 35 years too. I'm on a switch like this. But in anesthesia for a long time, it's been a common practice to use drugs off-label that are very useful, namely for OB, GYN pain, the spinal canal, the visual space. I think it was in fentanyl forever. Yet, up to now, I don't know if somebody would sue if something would happen, but I know it's been used for what, 15 years. And there's no, and I understand we're in a very tight position politically, but is there a way to prove that it's beneficial and get to use it off-label?
Well, you know, we all use drugs that we use them in an off-label manner. But growth hormone, because it fell into the FDA microscope, it's different. Unfortunately, it's different.
Even though Pearls has convinced the FDA that there has to be a stim test to prove you have deficiency, has he also convinced the FDA that you can't? It's contraindicated in past history of malignancy, or is that just something Cenogenics does? Just and especially in view of the fact that you just pointed out that there's not one shred of medical evidence in the medical literature that shows that there's an increased risk of CA.
That's just our Cenogenics conservative approach.
Okay, but it's not on the package insert that it says.
I think it is.
Contraindication for
I
malignancy.
think it is. I think it is. I'm not 100% sure.
And lastly, do you know if the FDA has prosecuted any physician that has prescribed it for himself or herself?
I do not know that, but I think that's not a good thing to do. To prescribe a controlled substance for yourself is putting yourself at great risk for the state medical board to be knocking on your door, or the SWAT team coming through the door from the federal government.
I have two quick questions, if I may. Firstly, are there any statistics on mortality rate from the insulin stimulation test?
I don't know. I have not seen any. It's not done a lot because it's very involved and complicated, and it's risky. And I don't think endocrinologists do it very much. And then, if they decide someone needs a stim test, where do they get it done? It's not. You just can't send someone over to the lab and get a stim test done. And we've actually looked long and hard for places where we can do the glucagon stim test, and there just aren't any. So I would venture to say that there's no one doing insulin stimulation test, hardly at all.
The second question is, from Australia, of course, we have slightly different rules to the rules you have here, and we are at least nominally allowed to prescribe growth hormone off-label. Have you had any experience or any observation in your clinical practice of growth hormone being useful in pain relief?
Well, no, I can't. I think it would. I think it helps. Definitely helps speed up recovery from surgery, from an injury, from overtraining. But as far as using it for pain relief, I don't know.
The reason I ask is that we have a long-term patient with chronic pain who was an assault victim, and he's adamant that the opioids that his local doctor prescribes just aren't working. The only thing that works in pain relief is growth hormone. And we're in a big argument with his insurance company at the moment.
So he says it's really helped him.
Absolutely. He virtually no pain on growth hormone.
That makes total sense. Makes total sense. Yes.
Hi, Dr. Life. I'm Dr. Lee. I'm an endocrinologist, and I've done growth hormone for over 15 years. So I've done hundreds of insulin-induced hypoglycemic tests, and knock on wood, I have not had any problems. I've dropped their blood sugars down by finger stick close in the 40s. By blood test, they'll come in the 30s. But I rapidly reverse it, and to me, that's the gold standard test. I was trained in that. I've done kids. I've seen a lot of short stature kids who desperately need growth hormone. And one of the reasons I kind of left conventional endocrine was insurance companies just getting harder and harder for, especially the kids, especially the small boys that are desperate and needing growth hormone to catch up. So in terms of insulin-induced hypoglycemic tests, they're not that hard. It's just you have to be trained and you have to have a really good staff in doing it. Unfortunately, there's not many endocrinologists, I think, across the country that does this test, but it just all depends on their training.
Well, wait, don't leave. How do you feel about treating growth hormone insufficiency?
I try to use secretagogues for growth hormone insufficiency. If they fail that, then I basically pursue insulin-induced hypoglycemic tests, and then basically most of them may qualify for growth hormone because a lot of my patients want to have their insurance company cover it. If they don't hit above 5 with their blood sugar dropping, and they're like 6, I say usually next year we'll repeat it, and you'll probably qualify at that time. So it's just a number game with the insurance company.
But if you didn't have to deal with the insurance industry.
Oh, if you don't have to deal with the insurance company, yeah.
So you would feel comfortable prescribing growth hormone for someone that...
I mean, you have the FDA, who's, it's just I don't want them knocking on my door. So I've prescribed hundreds of HGH, but they all qualify. I have a patient who goes, I want growth hormone. I go, that's fine, but if you're not doing this test, I'm not going to write it for you.
So you only prescribe it for people that have taken the insulin stimulation test?
Yeah.
Okay. How about glucagon?
I don't do much L-arginine. I mean, I've done it I mean, you can get it. It's just test, right? But for gold standard tests, because the insurance company will say, you have a second test. They never argue with this, basically, insulin-induced hypoglycemic test.
Okay, one more question.
Sure. Yeah. Oh, I'm sorry.
Oh, no.
I am also an endocrinologist. I've been doing stim tests for years in pediatrics and adult endocrine, but not the last few years. And if you really look at JCNM, look at some of the authors like George Merriam and others, there's a lot of language around it saying the IGF-1s are actually more useful because you get constant levels over time. You're not looking at one moment in time. But endocrinologists as a group, in my experience, from both pediatric, adult endocrine, GYN, and andrology, are all fairly conservative, particularly adult endocrinologists. They're not going to jump on board this until they're 100% certain that there's data that's going to confirm what they do. They tend to be isolated in the area that they work, and they don't tend to be very open to looking at these kind of values. But actually, in the literature, there are many places, including the endocrine guidelines, that say you can use, there's a variety of conditions where growth hormone may be useful, and using IGF-1 as a guideline. Not accepted by insurance companies, they won't pay for that, but that's what I find to be the most useful.
Okay, thanks. Time is up. I'll be out there if you want to ask me more questions. Thank you all.